All right. Welcome, everyone. This is Kristen with AHA and Debbie here as well. And we're happy to have Dr. Westley here for our second module on antimicrobial stewardship. This time we're talking about respiratory tract infections. Debbie already put the slides in the chat for you. We will be emailing them out as well afterwards. And in a second, I'll put the information for CE. We have approval for physician, nursing, and pharmacist CEs today for the whole series. So you can click on that link and click the module that you attended and do the questions for those. So without any further ado, I'm just going to pass it on to Dr. Westley for our presentation today.
Okay, great. Thanks, everyone. So let's get started with Module 2. I'm going to be focusing on respiratory tract infections. Here's the statement and disclosure for today. So our objectives for this module are to, first of all, just recognize that this topic, this infectious syndrome specifically, is the most frequent indication for antibiotic use in the hospital. And it's really the categories of pneumonia that are going to inform us what are the appropriate empiric antibiotics to select. And so we'll go through all of those today. And then we're going to talk about what data drives how we choose what to use and how long to treat it. And we'll talk a little bit about some rapid diagnostics that can help early narrow our antibiotics when we need to use broader regimens. And then we're going to talk about best practice for antibiotics for COPD exacerbation or exacerbation of chronic bronchitis, and then reiterate that antibiotics should not be given for acute bronchitis. So at Providence, when we first started our program years ago now, 2013, in the first 2.5 years, we had done 6,900 interventions on antibiotic use, and 28% of those interventions were respiratory tract interventions, and it was by far the most common type. The main things we do when we intervene in people receiving antibiotics for respiratory infections are changing of the medications, either what class they're using, or potentially what dose, the duration of therapy we make comments on, and then of course switching from an IV to PO. And so really this is a low-hanging fruit and bread and butter of clinical antibiotic stewardship programs and prospective audit and feedback activities for stewardship programs. So something that everybody will get a lot of experience with whether we want it or not. And so it's really important to have a sort of strong process in place and understand where that literature comes from. This is just to reiterate that, in fact, what we do with these programs can make a difference. This is Katie's paper from Providence that Ryan and I were also a part of, and this was published after our last modules update some years ago. But you can, oops, what's going on? There we go. But you can see that before our stewardship program on the left column, and then 1 and 2 years after the stewardship program started, length of stays and the inpatient duration of antibiotics and total duration of antibiotics for patients with community-acquired pneumonia improved substantially with statistically significant values on that improvement. Obviously, other things throughout the hospital might have helped with durations of stay as well, but just looking at community-acquired pneumonias, these numbers got substantially better after the program initiated, and there are many publications for the same. And in fact, there was a trend towards improved mortality, though it did not reach statistical significance. Anytime mortality is lower, that's kind of exciting. So what is community-acquired pneumonia? And this is basically pneumonia in a patient without risk factors for nosocomial organisms. Somebody who's not in the hospital or has not very recently been exposed in a way that is going to make them more risk to have resistant bacteria. So we're going to talk more about that through the talk here today. The subcategories of community-acquired pneumonia, we basically talk about outpatients that are either seen in clinic or the emergency department and not ill enough to need to come in the hospital. People that are admitted, then we break them into severe or non-severe categorization, though our pathways actually use the same regimen in both situations. There are some patients that will be at increased risk of MRSA or Pseudomonas specifically. And then there's a whole separate category of lung infection that are lung abscesses or empyema, pus in the pleural space around the lung, And that's a slightly different process. So we'll talk about that. The regimens that we use to treat these depend on what organisms we expect to have involved, be it normal bacterial organisms like pneumococcus or atypicals like Legionella, Mycoplasma, etc. Pseudomonas perhaps, or bloody sputum from the community might be an indication there could be Klebsiella pneumonia. And then with a lung abscess, there are frequently oral anaerobes. So we're going to touch on that. So first question is, should cultures be obtained in patients with community-acquired pneumonia? We're specifically talking about lower respiratory tract cultures. And it's still in the hospital, not uncommon for us to see people admitted to the hospital and not have cultures. What are the current guidelines, which all these superscripts here will relate to the literature cited at the end of the paper, so you can pull the papers if you want. So in outpatients, no. If you're in clinic and you try to obtain a sputum culture for bacteria from a patient, it's going to take many hours or even a day for that sputum to get to whichever lab processes it, and it's just going to be overgrown with all kinds of mouth flora. So it's really well described that sputum cultures for outpatients in clinic are not beneficial. But in inpatients, we do like to obtain lower respiratory tract cultures, and the current guidelines from the American Thoracic Society and the IDSA say that if there's a severe pneumonia, which is like an ICU level pneumonia, or if the patient is being started on MRSA or Pseudomonas coverage, or has had MRSA or Pseudomonas in the past, then they should have sputum cultures obtained. And the last group is that if a patient was hospitalized and received IV antibiotics in the last 90 days, their sputum should be cultured, because otherwise it's really not knowable what type of organisms are in the lung that you need to treat with antibiotics. So looking at empiric regimens for community-acquired pneumonia, again, these are from the IDSA and ATS guidelines, which were updated in 2018, 2019, something like that. So for outpatients, they are now recommending, and we're trying to streamline to amoxicillin 3 times a day for 5 days. And this is in otherwise basically healthy people that don't have chronic heart, lung disease, renal disease, diabetes, alcohol, malignancy, or asplenism. So that's a hard list to remember. And many patients with pneumonia in the outpatient setting are going to have one of those risk factors. But for an otherwise basically healthy person with pneumonia, amoxicillin is recommended. We do not recommend azithromycin, and we really don't recommend doxycycline monotherapy anymore due to low pneumococcus susceptibilities, which are followed in Alaska. Doxycycline could be considered in somebody with an allergy to penicillin who's got a mild pneumonia, but we don't do it often. Most patients that have outpatient pneumonia have one of these risk factors, and so frequently a combination of amoxicillin claviolinate plus azithromycin is used. It's on our pathways, and that is what the IDSA and ATS recommend for outpatient pneumonia if any of those risk factors are present. Now, when somebody's admitted to the hospital with community-acquired pneumonia, if they do not have a specific risk factor for MRSA or Pseudomonas, such as having had it before or had antibiotics recently in the hospital, then we are using ampicillin sulbactam and azithromycin regardless of the level of severity. So this either could be on the floor or in the ICU. And I'm going to talk in a little bit in a minute about why we use that combination now. If there's an anaphylactic penicillin allergy, levofloxacin alone could be used. There's some argument in the ICU as to whether a second drug is also required if you use levofloxacin in the ICU for severe pneumonia. But these are generally the pathways we use, and most patients can tolerate this. If they get a rash on ampicillin, sometimes you could just use ceftriaxone. And our prior pathways had ceftriaxone on them, but I'm going to talk more about that in a minute. If the patient had MRSA in the lower respiratory tract in the last year, then that needs to be treated because there's a high chance if they have pneumonia again in the near future, there is going to be MRSA in there. And so linezolid is a really nice option, 600 twice a day. If the patient's nasal MRSA PCR or NAT, nucleic acid amplification test, is negative, then actually the MRSA treatment can be stopped, even if you don't have a sputum culture. And that can be done basically right away as soon as that comes back. Those tests at hospitals that actually have them should come back within an hour or two. If the patient had Pseudomonas isolated from the lower respiratory tract in the past year, then that should be covered. And the best way to do that is to change the ampicillin sulbactam to cefepime or piptazo. And then if a patient has an empyema, pus around the lung, or an abscess in the lung, a lung abscess, there will be anaerobes frequently there, such as Preventella fusobacterium or anaerobic strep species. So ampicillin sulbactam is really the best option. Ceftriaxone and metronidazole would be another consideration. However, if somebody just vomited and then got pneumonia, they do not require anaerobic treatment. Anaerobic treatment is really only necessary if there's an abscess or an empyema. Now, if patients have been in the hospital and received IV antibiotics in the last 90 days, that does increase the risk that there could be a resistant organism in the lung. So if the patient is not in the ICU, if it's an admitted inpatient pneumonia, but they're not severely ill, then we recommend sputum cultures and also blood cultures. But the regimen that you start them on can still be the same as someone that has not had MRSA or Pseudomonas, as long as they never had that before. So we still endorse ampicillin sulbactam and azithromycin. We wait for the cultures, and if we need to alter the antibiotics based on the culture results, then we will do that. But if the patient's admitted to the ICU and had been in the hospital in the last 90 days and had IV antibiotics in the hospital in the last 90 days, then the empiric regimen should include coverage for MRSA and Pseudomonas. Cultures and PCR can be obtained, and then the antibiotics can be narrowed once that stuff comes back. So they're basically, prior to the 2016 update, anybody that had been in dialysis or was getting like outpatient infusion center or any type of contact with the health system in that way, or hospitalized in the last 90 days, everybody was given vancomycin and either piptazo or cefepime when admitted to the hospital. And then we subsequently learned that that was not beneficial, and we were using unnecessarily broad antibiotics in those patients. So this is really paring back what was done from about 18 years ago until about 6 years ago. Now, we have moved to ampicillin sulbactam rather than ceftriaxone for community-acquired pneumonia at the hospitals where I run the programs. And that is because there's quite a lot of literature that suggests that beta-lactam, beta-lactamase inhibitors like amsulbactam or piptazo really predispose much less to evolving extended spectrum beta-lactamases. And there's also less risk of C. diff diarrhea with amsulbactam or piptazo compared to third or fourth generation cephalosporins. So as an example regarding the C. diff, when cefepime was in short supply, when piptazo was in short supply in the country about 8 years ago, there was a big shift to cefepime. More C. diff was seen at that time. So we know that, and we've seen that, and if you look at the susceptibilities of Clostridium difficile, many strains are still susceptible to ampicillin and piperacillin, but they're virtually all resistant to third and fourth generation cephalosporins. And then there are many studies suggesting that third and fourth generation cephalosporins are the largest risk factor for developing ESBL infections in the hospital. This is just one study from China from a couple of years ago, but it's an example where 13% of the patients with ESBL bloodstream infection had received cephalosporins in the 30 days prior, whereas only 4% for those that had a non-ESBL E. coli had received those drugs. And usually the indication for the cephalosporin was actually UTI, quote unquote UTI, in the hospital, and then subsequently they had an ESBL infection. And so we're trying to avoid ESBL problems in our hospitals by using more amsulbactam. rather than ceftriaxone. Now here's the most sort of cited paper on nasal MRSA nucleic acid amplification tests for stopping MRSA therapy very early in the treatment of pneumonia. This is from Brown, actually, where I did my fellowship. And what this basically shows that whatever type of pneumonia is present, the negative predictive value, which is the far right column, whether this is ventilator pneumonia or community-acquired pneumonia or what they used to call healthcare-associated pneumonia, we don't use that term anymore, but all forms of pneumonia, the negative predictive value of a PCR from the nose was 94.8 to 98.1. So highly arguing against having MRSA pneumonia if your nose PCR is negative. This data is not the same as with a culture. So this is PCR specifically, not nasal MRSA cultures. Very few places do nasal MRSA cultures. They're not fast, which is the whole point of this test, is it comes back right away. This is also more sensitive. So this is PCR data specifically. We pulled 6 months of data in 2000 at Providence to make sure that this data held true at that facility, and the negative predictive value for all pneumonias was 98%. So a nasal MRSA that was negative had a 98% negative predictive value as well at our facility. So talking about azithromycin, because again, our mainstay is ampicillin sulbactam plus azithromycin. We give 500 for 3 days. It always seems easier to take something for a shorter period of time rather than the more traditional dosing of 250 milligrams for 4 days after the initial 500. So we give 500 for 3 days. There's a lot of data to support that. It's the preferred atypical coverage. There's data that combination therapy may reduce mortality in pneumococcal bacteremia. And when you compare outcomes in the ICU with azithromycin and a beta-lactam versus a quinolone and a beta-lactam, the patients that got azithromycin and a beta-lactam did better. There's a tiny cardiac risk in a big VA study, very tiny risk, but the benefit of survival actually outweighed a tiny increased risk of cardiac events. This is a study from intensive care medicine in 2010 about severe pneumonias, and the regimens that included macrolides, the patients had a much higher chance of survival. This wasn't randomized data, so there are problems with some confounding in the illness of patients, but it's quite accepted right now that macrolide is the preferred atypical coverage in the hospital. So there's been a nice trend towards decreasing durations of therapy for all infectious disease syndromes and a big part of antibiotic stewardship, and same thing for pneumonia. So a patient who has a working mouth, a working GI tract, and a working sphincter down at the bottom should be able to take oral therapy once they're able to actually have stuff go through the GI tract and absorb the medication. So once somebody is not critically ill in the ICU on vasopressors, et cetera, they're hemodynamically stable, they're taking orals. If they're clinically improving, they can switch. Basically, as soon as hemodynamically stable and taking PO. We probably start too many patients on IV antibiotics when they're admitted to the hospital for mild to moderate pneumonias in the hospital, when they could just take oral antibiotics even up front potentially. So after the following durations, we typically want to stop. We do expect patients should be afebrile for 24 hours when the antibiotics are stopped. Usually fevers go away pretty fast when pneumonia is treated. So 5 days is currently the recommended duration for community-acquired pneumonia treatment, either outpatient or inpatient, in the IDSA/ATS guidelines. If the pneumonia is from MRSA or Pseudomonas, the recommendation is 7 days. So it's 5 days for everything except MRSA or Pseudomonas, which is 7 days. Also can point out that pneumococcal bacteremia doesn't change the recommended duration of antibiotics, and it's not uncommon that we'll see or hear about a patient that had pneumococcus in the blood from pneumonia and improved rapidly, and the treatment team's plan was to give 2 weeks of antibiotics because there was bacteremia, and that's not necessary. 5 days of antibiotics is totally fine. The patient has pneumococcal pneumonia, even if they were bacteremic, as long as they don't have meningitis or endocarditis or something. And they can finish with oral antibiotics. Okay, so we'll talk about hospital and ventilator pneumonia now. Specifically, let's go over the definition. So hospital pneumonia is pneumonia that onsets more than 48 hours after admission. Ventilator pneumonia is pneumonia that starts after 48 hours of intubation and mechanical ventilation, so 48 hours after being put on the machine. Pneumonia that starts less than 48 hours after admission to the hospital is community-acquired pneumonia, so you can just treat it that way. Okay, so in 2016, the IDSA and ATS revamped their hospital and ventilator guideline and removed that healthcare-associated pneumonia concept and made substantial changes. These changes were made before our last modules in 2018 that we did on these topics, so I'm not going to belabor a lot of these, but there were big changes and they're still filtering through even 8-9 years later. But I think we're making progress on getting to a good place for these treatments. So our current algorithm is that we definitely want cultures because we would like to know what kind of resistant organisms we might be dealing with. And we also try to do a nasal MRSA NAT on all these patients that are starting antibiotics in the hospital for a hospital or ventilator pneumonia. However, we don't want to delay the antibiotics while getting the cultures. So if a patient's got pneumonia, meaning the X-ray has no opacity, they have fever, white blood cell counts elevated, et cetera, they're having problems with gas exchange, they need to be put on antibiotics while the cultures are obtained. And then the regimens that we use are based on the 2016 guidelines that are still the current guidelines. When the cultures come back, we target what we find and we treat for 7 days. It's important to point out if invasive lower respiratory tract cultures, this could basically be an endotracheal cultures or a bronchoscopy culture. If these cultures are obtained right at the time that pneumonia is suspected prior to starting the antibiotics and the cultures all come back negative, as long as the patient is better, typically the antibiotics can be stopped. Those cultures from an endotracheal tube or from a bronchoscopy are very sensitive. It's not common that they don't grow, but sometimes they don't. And if those cultures don't grow, then the antibiotics typically can be stopped at 48 to 72 hours. More often, though, antibiotics get started and then endotracheal or bronchoscopic cultures are obtained hours or a day or two later. Those are not reliable. But in the optimal situation where a pneumonia is suspected, a bronchoscopy is done, then the antibiotics are started afterwards. If the cultures are negative, typically the antibiotics can be stopped quickly. So we get the PCR and lower respiratory tract samples, and then we treat with an MRSA and Pseudomonas active regimen, vancomycin or linezolid plus cefepime or piptazo. And I'm going to talk briefly about which of those combinations might be better. If the nasal MRSA PCR is negative, then the vancomycin or linezolid can be stopped typically after the first dose because those PCRs come back very quickly at our facilities. At 48 to 72 hours is the time, 48 probably is the best time to look at the cultures, evaluate what's growing, make sure the patient has improved, and then narrow the antibiotics. If patients aren't getting better after a few days, something's wrong. So everybody needs to step back and reconsider what the diagnosis is, what's going on, and see if some imaging or further evaluations are needed or bronchoscopy or whatever. So how do we know whether to use cefepime or piptazo? We don't really. This goes back and forth every few years. There has been, for the last 15 years or more, retrospective concern that patients that receive a combination of vancomycin and piptazo together seem to have more acute kidney injury. And because of that, and because all these patients had been getting vancomycin for days historically, this pushed us to using cefepime. But newer studies suggest this actually may not be true. So a randomized trial in septic patients that all got vancomycin plus either cefepime or piptazo showed that there was not an increased risk of renal failure with piptazo, but patients that got cefepime had substantially more neurological sequelae. This could be coma, this could be seizure, and that can be seen here. This is the ACORN trial, and the whole enrollment was blinded and done out of the EHR, so it was really cool. And they basically showed that delirium and coma-free days were improved with Piptazo. So there was no difference in major kidney events or acute kidney injury at all, but there was less delirium and coma in the Piptazo group. And especially now that we're not giving vancomycin for days and days and days anymore, this makes a lot of us think Piptazo is potentially as favorable as cefepime or even better now. So the last thing I should talk about there is what MRSA drug to use. Vancomycin has been a workhorse for like 50, 60 years for MRSA coverage. However, linezolid in 2024 has made some big strides. One problem was that historically linezolid was very expensive, $1,900 for 7 days of therapy, oral, and that's oral linezolid, not IV. And linezolid is not a drug to be used for endocarditis or endovascular infections. There is substantial data that it failures at higher rates. So if somebody's septic, not from pneumonia, but you don't have a source and you think they could be bacteremic or have endocarditis, linezolid's not your drug. But for hospital pneumonia, ventilator pneumonia, community-acquired pneumonia with prior MRSA risk factor, linezolid is probably the way to go. Now, oral linezolid is just a couple bucks a tablet, $35 for 14 tablets with a good RX coupon, for example, at Target. Our institutions pay a couple bucks a tablet. And the data is very clear that linezolid is at least as efficacious for vancomycin for MRSA pneumonia, both community-acquired pneumonias or hospital pneumonias, and possibly more efficacious than vancomycin. It's also less toxic. You do not have acute kidney injury problems, and you don't have to monitor drug levels. So many places are moving towards linezolid being a first option for coverage of MRSA pneumonia. So I thought I should probably also add recent literature here from 2024 that many people may have seen. This is called the ProfiVAP study. And the question has always been that we know patients with closed head injuries, neurological injuries that present to the hospital in coma have very high rates of ventilator pneumonia. And so the question is there a way to reduce that risk? So this study looked at ceftriaxone to prevent early ventilator pneumonia in patients with acute brain injury, early being in the first week. And this was a placebo-controlled double-blind study. And what they did was they gave ceftriaxone within the first 12 hours of intubation, a single dose, 2 grams. They had to have a GCS 12 or less. And in their study, 14% in the ceftriaxone group developed ventilator pneumonia versus 32% in the placebo group. This is the cumulative incidence curve, and you can see that it separates by day 3 or 4, placebo versus ceftriaxone, substantially fewer pneumonias in the ceftriaxone group. One of the things that was exciting about this study for antibiotic stewardship folks is that the patients that got a single dose of ceftriaxone, because they developed so many fewer pneumonias, they had a total of 21 antibiotic-free days in the ICU versus 15 antibiotic-free days in the group that was not treated. So many extra pneumonias in the untreated group that they ended up getting more antibiotics. So the argument with this study was that that single dose actually decreased the amount of antibiotics the patient would receive in the hospital. So that was pretty exciting. Is this ready for prime time or not? There are a lot of disagreements about this. And most of the criticism is that these are massive ventilator pneumonia rates. None of the facilities that I work in, even in the neurosurgical head injury patients, have a ventilator associated pneumonia rate of 32%, which is quite excessive. 14% in the ceftriaxone group is still very high. Most of our facilities get worried if the ventilator pneumonia rate is 10 or 12%, and we really want it to be 0 or 1 or 2%. So whether this benefit would be the same at a place with lower ventilator pneumonia rates is not entirely clear. A lot of this was actually European data, and in Europe, there's always been higher rates of ventilator pneumonia, but it's still an intriguing study. And There's another study called the Antarctic study. I won't go into detail here, but it basically looked at the same thing, a short treatment of early antibiotics in patients with shockable cardiac arrest and heart rhythms out of the hospital suggested a similar benefit. So we're doing something similar in GCS 8 or less patients at one of our facilities with early ampicillin sulbactam stopped if cultures are negative and there's no pneumonia. At least that's the intention of that intervention, and it seems to be working. So now I want to move on to COPD briefly. So chronic bronchitis or emphysema with worsening respiratory symptoms is what we call colloquially acute exacerbation of COPD or chronic bronchitis. And the categorizations are shown here. So mild just means you're having some dyspnea, but you have normal vital signs. You can be treated as an outpatient. Moderate means you're having shortness of breath, but something's going on with the vital signs, either hypoxia, tachycardia, tachypnea, and those people are typically going to be admitted to the hospital. And then severe would mean that you are acidotic. So your pH is less than 7.35. You may be going to the ICU. You may be getting rescue non-invasive or invasive ventilation. The GOLD guidelines are updated essentially annually. Those are the COPD guidelines from the pulmonologist. 2024 is the current guidelines. And they are really clear that antibiotic use is only for moderate to severe disease, so basically in the hospital, not for outpatients. And the data is not good. There's minimal placebo-controlled data, and meta-analysis suggests there's probably a near-term mortality benefit to antibiotics, but it's weak data. So to qualify for antibiotics, patient needs to be in the hospital with a moderate to severe exacerbation, and they need to have increased dyspnea and purulence, or be requiring mechanical ventilation, endotracheal tube or BiPAP. Those patients, so if somebody's got severe COPD exacerbation, they don't seem to have substantial increased sputum purulence, but they're in the ICU requiring mechanical ventilation, then we would give them antibiotics. Is there any way to know of the ones admitted, the moderate patients admitted to the hospital, whether they actually need antibiotics or not? Well, there are many studies of using procalcitonin in COPD to determine whether there's an active bacterial infection that would benefit from antibiotics, and I've just shown 4 of them here. I'm not going to go through them, but there's actually quite a bit of data, and we still endorse doing this. However, the GOLD guidelines don't. And the reason that they don't recommend a procalcitonin algorithm is that all the data they look at says that using a procalcitonin algorithm is not associated with decreased antibiotic use. They don't question that a procalcitonin in the studies, if it was normal, suggested that antibiotics weren't needed. What they're actually suggesting is that even when people get procalcitonins and they're normal, doctors still give antibiotics. So using a procalcitonin is not reducing antibiotic use, so they don't recommend doing that. However, many antibiotic stewardship programs still believe that if you pair procalcitonin use with an active prospective audit and feedback stewardship program, they can review those data and recommend either not starting or stopping antibiotics when the procalcitonin is negative, that there may be a role for using it. Probably most patients in reality in our hospitals don't get procalcitonins in this situation. If they do, they might be ignored, but they shouldn't be. If the whole reason to order a procalcitonin is to already determine clinically that if this comes back low, I'm not going to give antibiotics or I'm going to stop them. If the decision is clinically, I'm going to give the antibiotics no matter what, then there's no point in checking that test. So what antibiotics should we use for acute exacerbations? Nobody really knows. So the quotes from the guidelines say the choice of antibiotics should be based on local bacterial resistance patterns, which isn't a really helpful statement to most clinicians. And then they say an aminopenicillin with clavulanic acid, a macrolide, a tetracycline, or a quinolone for less than or equal 5 days is okay, which gives you quite a lot of latitude. And there's actually no compelling data to say that one regimen is better than another. Moxclav, macrolides, quinolones appear to perform equally. So you'd obviously want to pick a regimen that minimizes collateral damage to the patient. When we looked at this at Native, we actually pulled COPD patients to try to figure out what's happening, and most weren't getting any cultures, so we had no idea what organisms were in the lung. The ones that we did get cultures, the organisms mirrored community-acquired pneumonia, but occasionally there was a Staph aureus or a Pseudomonas. And so we still encourage cultures if somebody's got purulent sputum and you're going to give them antibiotics. It's intuitive to want to know what's in the lung that you're treating. And then we try to treat for less than or equal to 5 days with a narrow drug if the procalcitonin is elevated, just like we talked about. Many times patients just end up getting amoxiclav or amsulbactam or doxycycline or something for 5 days in the hospital and do okay when they get their steroids and oxygen. But that's what we try to do. Outpatients with mild exacerbation don't require sputum cultures or antibiotics, which we talked about previously. All right, so how about azithromycin or levaquin for COPD? This was a huge study. I can't remember if it was at the VA. I have to double check, but 19,000 patients given one or the other. And this basically all this data does is show you how confounded the data is. So here, this was a study looking at how many people got a quinolone and how many patients got a macrolide when they had COPD exacerbations. And the macrolide patients also got a cephalosporin with it in 59% of cases. Whereas, of course, the quinolone patients only got a quinolone alone because typically you wouldn't add a cephalosporin to a quinolone. So even the data that tries to separate out is a macrolide better than a quinolone or doxycycline or something for COPD is massively confounded by the variety of antibiotics people are getting when they're in the hospital. So it's just to say that the evidence base is really poor for this situation. And these are the outcomes here. And there's a suggested benefit to macrolide over quinolone for COPD from this study. But again, 59% of the macrolide patients got a cephalosporin as well. So it's very hard to know what to make of data like that. How about giving azithromycin every day for COPD just so that they don't end up getting sicker and ending up in the hospital? There is a very slight 1.48 versus 1.83 exacerbations in patients taking 250 daily. The hazard ratio is 0.73. This is a New England Journal study from 12, 13 years ago. However, hearing loss was higher at a year, which is always a bummer. And there didn't seem to be much benefit in active smokers. And many COPD patients, of course, are active smokers. There is also no data on safety or efficacy past 1 year of azithromycin, though many of us have seen people that have been on daily azithromycin for 5, 10, 15 years. There is no data to moxifloxacin or doxycycline given in pulse or chronic forms. So the GOLD guidelines take no stance for or against azithromycin in people with frequent exacerbations to minimize exacerbations for up to 1 year. And they specifically state there's no data to do it for longer than that. So the last thing we should just say is that for people with acute bronchitis or your other community-acquired respiratory tract infection du jour, which I may have right now, you can tell from my voice, there are multiple of those transmissible agents that antibiotics do nothing for. And acute bronchitis does not respond to antibiotics, and antibiotics are not indicated for that. There's really no ifs, ands, or buts about it. There's an increase in side effects versus placebo, but no improvement in symptoms when randomized. And to just make this very clear, we tried to make a very simple and educational acute bronchitis outpatient pathway at ANMC. And we're quite clear on the medication and the education columns here at the bottom that antibiotics do not help with this. We do point out that acute bronchitis means coughing in a patient that does not have COPD. So we're not talking about COPD. We're not talking about people that have had a transplant and have heart failure or something. We're talking about, your average outpatient who's been coughing for 2 or 3 weeks and wheezing, and the temperature's 99.1, and they just feel crummy and they feel like they're not getting better because their cold became a chest cold. And the data is is unequivocal that antibiotics don't help in that situation. So this should be one of the antibiotic stewardship never events. Okay, so here's our CE informational to get the CE. I've got all the links for various data that I presented here. So if you want to pull the papers, you can. And then I think what I'll do is just stop sharing now. Let me see if I can find our chat. And then I'll take any questions people have as well.
There's a question that just jumped in the chat. You're able to see it, Dr. Westley.
Is there utility to MRSA NAT after antibiotics have been started? And if so, what is the cutoff after starting antibiotics that we could trust a negative NAT? I should have presented that, and I will update the slides if I remember when I get home. It's either 48 or 72 hours. So if somebody, yeah, you don't want somebody to be on vancomycin for a week and then decide you want to stop the vancomycin and do a nasal PCR to stop the vancomycin at that point. So this needs to be done basically before or when the MRSA treatment is being started.
Does anyone have any other questions for Dr. Westley?
Feel free to come off chat too. I mean, off your mute.
All right. Well, if you
Oh, it looks like there's a question.
oh, go ahead.
Oh, sorry. I was just going to take it real quick. Dr. Westley, I think you said that no one was really live locally with the ceftriaxone single dose. Is that something that you anticipate kind of being put into practice in the next year or so?
I think if a facility, which all trauma facilities benchmark their ventilator pneumonia rates against each other. And if a facility is having above expected ventilator pneumonia in patients with head injuries and low GCS of 8 to 12 in that range, then one evidence-based intervention for decreasing the risk of early ventilator pneumonia in those patients would be giving a dose of ceftriaxone within the first 12 hours. So there aren't many trauma centers that deal with that stuff. I'm sure Fairbanks does, as well as here, especially here, native in Providence. And at Providence, when ventilator pneumonias were being benchmarked, the rates were felt to be suboptimal compared to comparator organizations, but we have always been using ampicillin and sulbactam as our drug. So we decided to use that rather than a single dose of ceftriaxone, still to just minimize the third and fourth generation cephalosporin pressure. But we're trying to do the same thing in that sense. When I've heard this study discussed in multiple podcasts and at meetings and stuff, there is a lack of agreement about whether this should be disseminated throughout, everywhere, because most places in the US do not have ventilator pneumonia rates anywhere near what they did in the European data. But I think if there's an issue with ventilator pneumonias and those type of patients are being treated, then that's something that might help.
Okay, thanks.
Yeah. Okay. Are we using linezolid preferentially for pneumonia compared to vanco? I am, and we're trying to move that way. Not all of our pathways have moved to linezolid, but we're moving them currently. And I think that is going to be the trend you're going to see a lot of places, and certainly here. If you have a positive MRSA nares, is the correlation to culture 100%? No, the positive predictive value is low. It's still only 30 or 40% positive predictive value, but it's like 98% negative predictive value. So you still need a lower respiratory tract culture, because if the nasal MRSA is positive, you still could have a pure Pseudomonas pneumonia. So you still need the cultures, but you would not want to stop the MRSA treatment if the nose is positive until the sputum cultures are back. But you can still stop the MRSA treatment once the sputum cultures are back if there's no MRSA in the sputum. Again, it's going to be 50-50 basically.
Lots of good questions. Anyone have anything else? Oh, there's another one popped in.
Yeah, so we're looking at our own data on this. I hope we're going to have a nice amount of data. As Shauna points out, so one of the residents is doing a project on this ampicillin sulbactam. I think they're getting, I'd really like to see them getting 24 or 48 hours only rather than 2 or 3 days. So they're getting a bit too much, but it's something we're going to keep working on. So we'll have some data on that. Okay, so there was so this next question is, do we recommend extending duration 7 days if moderate immune compromise, structural lung disease, etc.? That is actually not specifically, I don't think that's specifically addressed in the current guidelines. There was a nice study about antibiotic stewardship rolling out for lower respiratory tract infections 10, 12 years ago when a lot of us were working on these initially. And the algorithms that were typically used were 5 days if no lung issues, 7 days if moderate immune compromise or structural lung disease, and 10 to 14 days if slow to respond to treatment. And I think that, there's always a lot of gray area and art in treating these patients. So certainly if somebody is very, very slow to get better, but seems to be on the right antibiotics or has very extensive disease in the lung, we're not just going to treat them for 5 days or 7 days. We may extend the antibiotics because they're getting better slowly. But the criteria for when to stop and when to de-escalate are the same as I laid out. But certainly there are times we will treat a little longer. But I don't think it's mandatory to say that treatment has to be extended in all those patients. Okay, for linezolid, do you have specific direction for interaction with SSRIs? Do you have a number of medication interactions for which you... I meant to include that, and I should have. So there are multiple papers, one of them from Mayo about 5 years ago, that looked at antidepressants and linezolid and basically stated that while there's a theoretical interaction, there's really no clinically demonstrable increased risk of serotonin syndrome or any problems with those drugs. So the risk appears to be 1% or less. And so we don't worry about SSRIs or other antidepressants with linezolid anymore. And there's also data with methadone or Suboxone that looks like there's minimal risk and it's quite safe to give linezolid with methadone or Suboxone. So that has also made it much easier to use linezolid. If you can't find that study, Megan, you can reach out and I can share it with you.
Let's see if anyone else is typing. I think so. Thank you so much, Dr. Westley. If anyone has further questions afterwards, feel free to send it to Debbie and myself, and we'll get it to Dr. Wesley for that. And I just want to let everyone know that our next session is next week on Wednesday at noon on skin and soft tissues, and we'll hope to see you all there. So thank you all so much for coming.
Thanks, everyone.
Thanks,
Okay,
Dr.
take care.
Thanks, everyone.
Yep. Okay, bye.
Bye.